Welcome to the Da Vinci presentation that was presented during the August 18th, 2025 biweekly Da Vinci Trebuchet public meeting. Michael Westover of Providence Health System offered a provider's experience in the multiple ways they've tested sharing data with payers to support quality measurement. This presentation and all Da Vinci presentations are offered under the HL7 antitrust policy to ensure appropriate collaboration and information sharing.
All right. Well, thank you everybody for bearing with us on this one. I'm excited to talk to you today because our team has been experimenting with FHIR and trying to pull data to improve our clinical quality measures. And we've had a lot of successes and we've had failures and we've had things that we've learned, things that everybody accepts as true that we've learned are not true. And we want to get some things off our back. Like we want to share with you all the things that we've learned so that other folks can make steps in the right direction with us. I have a bunch of slides to go through. Like, feel free to post your questions in the comments, and like we'll try to leave some time at the end too, to ask some questions. So first, I want to set the stage with the problem. Um, I, Performance on clinical quality measures, I hope you all know, is incredibly important to provider organizations that want to help their patients, but they're huge financial incentives, and to payers who have to, like HEDIS, five-star measures, they're huge incentives for them to do well on clinical quality measures. And so this is an oversimplification, but on the right-hand side of the screen, you can see the patient, the way I picture it, at least in my mind, is that the payers set up, think of a patient, and they just check as much data as they can to that patient for clinical quality. They might have data coming from HIEs, information that's keyed into web portals manually. There are EHR platforms that are delivering data to the payers, patient charts that are pulled, non-standard supplemental flat files. All of this data is kind of pointing at those quality measures to try to increase the accuracy. A lot of these methods are incredibly inefficient and expensive. So when we look at ways to improve our clinical quality measures, some of the problems that we saw, were that, some of the problems that we saw externally validated data. So for quality information that happened at non-Providence facilities, but was in the Providence EHR, there were some issues with that externally validated data that wasn't flowing through the payers. We see local codes, so not things like CPT codes that are understandable for clinical quality purposes, but think of codes that are standard to Providence and only Providence knows that don't really mean anything to the payer that are flowing through. We have data hidden in the dark corners of the internet of our EHR, that was there in the EHR but wasn't flowing through to the payers in any meaningful way. There are poor transmission processes, like having an individual have to log on to a payer web portal and like copy information from one place to another is very expensive and inefficient. The audit processes are inefficient and expensive. And sometimes when the quality data is validated upstream, like the results of those audits don't flow back to where the source data is generated. Meaning you might have an audit that says, oh, we can't use this data, but there's no improvement to the data at the source so that it can flow through and become better in the future. And that kind of gets back to inadequate feedback loops. So there's the group that's generating the data, often at the HR, at the provider side. And then that data is flowing through to the payer, and then let's say to NCQA for HEDIS. But sometimes the results of that and what things need to be done to improve just are not flowing back. So we don't have this continuous improvement cycle. So we had some goals when we started looking at this. The goal is to improve clinical quality measure performance, but we wanted to do this in a way that didn't increase the burden on clinicians and administrators. So we were thinking, how can we reduce dependency on keying things into web portals and non-standard flat files? And we wanted those things to be reduced over time. And then the more efficient, scalable, technology focused ways to get data to the payers could improve, and we could just get better rapid cycles with improving that data. We also wanted to increase the amount of clinical data that's flowing for clinical quality measures. And I think the goal was to say, can we get all of the data for the work that is being done by our providers to the payers? So the work is being done. A lot of that's not making it to the payers. So we're not getting an accurate reflection of our quality. What can we do to make that better? We also wanted to make that data much easier to ingest for the payers. We deal with a lot of like pet data sets that we send to the payers, like homegrown files. Like, are there ways we can move to more data like national standards for sharing that data? to make things easier on all sides. Um, we also wanted to experiment with, is there a way that we can send only the data that is needed for the clinical quality measures? I think there are very good reasons to send more data than that for other purposes. But if we said, you know what, if we're going to extract data and just the least amount of data needed for this purpose, like we can become much more efficient, share the data more rapidly, have a strong QA processes around sharing that quality data, and just package it up with a nice little bow so that when payers catch it, they can push it through their systems quickly. We want to be good stewards with our and good partners. So then we wanted to reduce the cost of getting the quality measure data to the payers. And how can we do that more efficiently? And we also wanted to partner with groups like Humana and Cambia, and we have a bunch of other great relationships with payers where we have kind of a bi-directional data partnership where we want to be, the best in the country at exchanging this data, so that we can, perform on our risk contracts and value-based care, so that payers would like to partner with us in expanding our relationships. Okay. So here are some of the options that we looked at. I don't pretend to say that these are all of the options that are out there in the world. And I think that there's some different ways that we could look at some of these, but these are some of the options that we evaluated that I'm going to be talking about in more detail. And what I think is exciting is we can talk about pros and cons of each of these ways. I know that a lot of the vendors that pull data out of EHRs tend to use flavors of these data extraction methods. So I think as like we're learning about how to pull data effectively to improve clinical quality, and I think this is a starting off point for a lot of the other use cases that require data out of the EHR. I think we can have an interesting discussion. So the first one is pulling data out of the EHR's reporting databases, and we'll talk about that in more detail. But EHRs tend to have a reporting database that provider organizations used, and they can run automated scripts and SQL queries and all of those good things that are commonly used to send data to vendors and to payers. We'll talk quickly about using payer platforms like Epic Payer Platform. I know that there are other platforms that EHRs are developing too, and we've had experience with that. We're going to talk about national network approaches and look at the HIE type approach of being able to exchange clinical quality data to close quality measures. TEFCA has talked about, I know there's a lot of talk right now around the nation at the highest levels and policymakers about how can we exchange data through networks more efficiently. I want to talk about CCDs and HL7v2 messages. This is not something that my team looked at specifically, but I think we can talk quickly about it. And I know other parts of Providence do this for other purposes, but CCDs are commonly used for clinical quality measures, for example. I also want to talk about how it is possible for payers to connect directly to EHRs through G10 API, so a direct connection. We could talk about how that works. The next option is one that we evaluated but did not implement. Is we looked at pulling the entire patient record out of the EHR and then loading that data into a server and then sharing that record with the payer. And we'll talk about that. And then we also looked at pulling just the relevant resources related to clinical quality or related to quality measures and sending that with the payer. I think you might be able to come up with other options, but I think this is a good set. And if you're interested in clinical quality, like you're a payer, provider, or you're a vendor that works on this stuff, I feel like this should be an interesting conversation. We've learned a lot through our mistakes. Okay. So, and Vanessa, if there are any interesting questions that come up or clarifications, if you could just stop me, feel free to jump in. Yeah.
You got it.
Come up in the chat. Okay, so the first one is, what if we use the EHR's reporting databases that have been around for a while? And let's look on the right-hand side to give you a rough overview of how it works. So you have your EHR. Nightly, that EHR makes a copy and puts the data in a reporting database. And that reporting database, the one we work with, has over 18,000 tables. And then you have an analyst, that's a picture of this individual working on the computer, that'll write a query using SQL. And we actually tried to do this. So writes a query using SQL and translates the data from the reporting database into an HL7 file format. And then we expose that data to our payer partners, using APIs. Now, some things that we learned, I'm going to put this in a pros and cons format. So some nice things about this are that, these reporting databases have been around for a while. They're well established. They have strong data dictionaries. There are lots of analysts that feel comfortable with this data, working with this data. You can automate those queries. We found that you can get into a situation where you write hundreds of data queries for different purposes and you automate them. And they're using something like 27 joins. You're combining 27 or 15 different tables together, and you automate it, and then you forget about it. And then 2 years later, it breaks because something that happened in the underlying EHR structure, and then you can't find the person who wrote the query, and you have to go back to it. But this is a way that things are commonly done. Also to work with vendor products too. Someone writes a query, and that data is shipped off over to the vendor. So most providers already pay for and have access to these reporting databases, so it's relatively inexpensive. Now, on the con side, these queries can be incredibly complicated and mapping can be difficult. The data structures can also change underneath as the EHRs are updated, and then you need to go update your queries, and you can have thousands of these, right? And it can be difficult to get the data to match the EHR front end when you're working with these reporting databases. It could be your query, it could just be some of the data is hidden and special in a table, or maybe it was built in your specific instance in a different way, and that might not flow through to your query. And our experience was that when we use this method, we had trouble maximizing the amount of data that was flowing for quality measure purposes. Okay, should we go to number 2? All right, option number 2. So pull the data using a pair platform. So on the right-hand side, overly simplistic way that it works is, so the provider is using the EHR software and data is being stored underneath that EHR platform. And then the payer has access to the payer platform. And that payer platform essentially aggregates all of the EHR data from all of the providers that have allowed access to the underlying data so that the payer can work with it for approved purposes. And so what's different about this is that it's not the provider and the payer connecting directly, but they're basically communicating through the EHR partner. I mean, through that EHR software, through that payer platform. I know that Epic has a payer platform that's talked about a lot. I know that there are other EHRs that are developing payer platforms like this. And Providence has implemented a payer platform for a few payers. And so we have some experience with it. I know other provider organizations have experience with it too. The pros are it's relatively easy to set up and manage, especially from the provider side. And the EHR is taking responsibility for managing some of the data exchange, managing things like data duplication and some of the complexity around it. And that the EHR organization can support multiple payers and multiple providers through their platform. So instead of having to connect directly to multiple payers, you can connect to the EHR and that'll support multiple payers. Now, those are some of the pros. We can talk more about them if anybody would like to get into it another time. But then some of the cons that jumped out to us were this method only works if the providers and the payers are all using the same payer platform. So we have payers that are not using the platform, and we have to come up with other ways, other scalable ways to exchange data with them. So the EHR platform solve maybe some of the problem efficiently for us, but not all of the problem. So we needed other ways to exchange data efficiently. These can also be very expensive for payers, and the payers that have implemented the EHR payer platforms with us so far, they're still asking us to provide supplemental clinical data to them because working with some of the data from the EHR platform is a learning process, and that will happen over time. So this is just my experience. Perhaps you've had other experiences that I'd love to chat with you about too. Okay, so now let's talk about the national network approach, the HIE approach. There are lots of HIEs and there are lots of national networks, and they're evolving rapidly. So it's hard to talk about these in aggregate. And I think we could easily have an hour conversation just about this one. But we could talk about some of our experience with it. So instead of connecting to individual payers to exchange data, the idea here is that a provider, you look at the green on the left-hand side, will connect to the network, and then that network will be the funnel or the pipes to share data with each of the payers, in theory. So you get a bunch of payers together, a bunch of providers, you each agree on creating that network, And in theory, you could use that network to share data for clinical quality measures. And there are a lot of benefits to this. I think there's a lot of potential, and I feel like this is where the world seems to be going, in which like ONC, ASTP seems to be very supportive of these kind of network scalable opportunities to exchange data. So some pros about these approaches, the paperwork with new partners is relatively simple. So you kind of sign the agreement with that network, and then anyone who belongs to that network will be able to exchange data for the purposes that you've outlined in the contracts and BAAs that you've signed up with the network. Data, you can see how this data exchange is possible. So if the network is set up appropriately, you could imagine a world where payers could be sharing data and providers and everybody could be going in and getting the data that they need. Now, some of the cons on this, and I think this is a big one for some of the networks that we looked at, are that the network participants may refuse to share data related to clinical quality data extraction. So when we're talking about sharing data with payers, this is not necessarily a treatment purpose. You can think of this as an operation, like operations purpose. And let's say if a payer were going to come in to pull the data from a provider organization or from the provider's EMR, there's no requirement that that data is pulled over. So we've also run into situations in our experience where there were providers and a network that we were trying to pull data for that, but even though they were a node on the network, they weren't necessarily feeding data to the network, or we ran into issues with patient matching, which was a difficulty, and patient identification. Uneven data quality, difficulty providing data feedback. And I know a lot of people are working on really hard to fix these issues, but they are things that we ran into when trying to do these scalable networks. So I think these have a ton of potential. I'm excited about the possibility of them, and would love to keep talking about it. Okay. So now HL7 v2 messages and CCDs. This is another example of ways to exchange data for quality measures that our team did not implement, but we looked at. On the right-hand side of the screen, if you think of a CCD, definitely have some values that continuity of care document. So think of that as this block of data that has a bunch of information, the patient's longitudinal record, which includes a lot of information that could be used for quality measures. The nice thing about these CCDs are that you don't have to jump through some of the technology hurdles that you might when you're talking about FHIR. If you think of you don't have to register the apps, and my team had to spend a lot of energy going through, fighting with the information security team to make sure that we could provide the data via modern APIs. Some of those things you might not have to deal with. Also, those CCDs are not as chatty, and the files are not as large as a complete FHIR data, as the FHIR data that has the entire US CDI patient data set. The data, and this, the CCDs and also the HL7 V2s have been around for a while. And so I see a lot of HIEs and provider organizations that have established ways to share that CCD data. So I think there's promise, with that CCD data as a way to exchange. Some of the downsides are it's not human readable like FHIR, and the data can be hard to work with if you don't have experience with it. So there are organizations that have a lot of expertise with it, but if you just opened it up and looked at it as CCD for the first time, it can be hard to work with. The CCD data is not as robust and complete as FHIR, so that means it's a smaller data set. It's more targeted. You can iterate with it relatively quickly, but it's not as complete as the FHIR data set. And you have a lot of data that is unrelated to quality measures that it could be included in that CCD. So if you just wanted to share data related to quality measures, CCDs might not be a good choice. Also looking at the HL7 v2 messaging. So that's built around more event-driven real-time data flows. Think of a lab feed or admission, discharge, and transfer feed related to a hospitalization. So the nice thing about this is it's real-time, it's event-driven. The data often comes from the original source. It's not being passed through different stages and hops as it's going to you. Now, some of the downsides, and I think these are important downsides to consider, is that those HL7s by design are missing historical data, and they might be missing some information that you need for quality measures. And when I talk to folks, they tend to say that when you're talking about pulling data for quality measures, historical data extracts by their nature will be more complete. They'll have more history, and they might include other things that might not be there for the HL7 V2s. All right, let's keep moving. So option 5, I think this is a fun one to think through. Have the payer connect directly to the EHR's G10 APIs. For those who don't know what those G10 APIs are, so for any EHR to get certified, they need to be able to expose clinical data, so a core clinical data set called like the USCDI, using data standards, using FHIR, and that those need to be available, like produced by the EHRs. So in theory, a payer organization could do a direct connection to a provider organization's G10 APIs and pull the relevant data needed for quality measures. So this is a possibility. And the way it would work is that a provider organization, would ask the payer, like sign any paperwork. They would have to come up with agreement of how can you use this data, what things can you use it for, things like quality measures or treatment or operations. You can decide, right? And then the provider would grant access to those G10 APIs to the payer. The payer could then pull data for individual patients or populations, um, whenever they would like to. It's a pull method. And the payer could use that data for appropriate purposes. So there's some potential here. And let's be honest though and talk about some of the pros and cons. So the nice thing is it's relatively easy for providers to allow an organization to have access to the G10 APIs. The data pulls from a provider perspective would be simpler than having a provider, work with an EHR database to write queries and something that's very specific for a payer. This would be FHIR formatted information. And it also this direct connection method may be a cheaper way for payers to directly access an important partner provider organization's data without the need for a payer platform. So payer platforms can be expensive. This might be a cheaper option because it is a requirement for certified EHRs to offer that payers can allow organizations to get access to, like a payer. Now, some of the cons are it requires point-to-point connections to each. If let's say you wanted data for 10 EHR or from 10 providers, the payer or the payer's delegate, if they're working with a vendor, would have to connect to each of these organizations individually. The payers might not have expertise with the G10 APIs. And then also, I think this is an important one, is that those APIs might not be able to support like those bulk queries or in real world situations. So our experience when testing some of these G10 APIs are that because they're sitting on the production environments, if you're pulling data for a large number of patients, think of it, not individual patients, not a panel, but for a population, sometimes these queries can get bogged down and take days or weeks or years, depending on how you've structured them. And they can also impact the EHR's production environment. So I think these are all factors that you need to consider. Okay. Now, here's another one that we looked at, but we did not implement. I know that other organizations are poking around at this one too. So this is where a provider organization will pull data out of their EHR and then combine it with other administrative data. Think of the whole USCDI, think of it as the patient's chart or the patient's record, and then share that information with the payer. And it would include information for quality measures, but it could have other information too. So, and the way Providence did it is, or we thought about doing it, but we did not, is that we would pull the entire USCDI patient record in a FHIR format from the EHR's G10 APIs, and then we would combine that data with payer information. So the payer member roster would tell us which members we need to care about, and it would have other claims information that we would get from the payer. So we would then combine the EHR data and the payer data on the back end, and then load that information onto a FHIR server for a patient. So for Michael Westover, it would have a combination of the payer data and the EHR data, and we would pull all of the EHR data for those members in the roster. And then, in theory, you could share that entire patient record with the payer for various purposes, including getting clinical quality data. But what we looked at is, what if we could then bolt the NCQA's HEDIS value sets to their product called DCS? And what if we could filter that data so that we would only send the information that was relevant to the payers, and we expose that information through modern APIs. And we can talk. And we had a fascinating experience with this. And just a couple things that we learned from this are if you try to pull the entire patient record out of the EHR, that can take a while. That's one thing. When we attempted to filter the data using the DCS product or the NCQA's HEDIS value sets, there were some limitations on that product that were built for payers, but were not necessarily built for providers, meaning a provider doesn't necessarily need to calculate the quality measure. We just need to take all of the information needed for quality measures and then share that with the payer organization. But if the tool required that we have all the information to calculate the measure, that tool might not be very responsive and might not meet the need for the provider. It feels like more of something that somebody might need for an organization that needs to calculate HEDIS measures. So we evaluated this and did not move forward with it, but we think there's promise here. So some pros of sending the entire patient record using the G10 APIs. So it could be a less expensive direct connection. It makes the provider an active participant in data exchange. So the provider's in a good place to like modify the data and kind of tweak the HR when things aren't right and make sure the data is high quality. And if the provider would like to be an active agent in this is a method to evaluate. And then it puts the provider in a position to evaluate quality. Now, on the con side, we talked about stressing the HR's production environment. The entire record also could include data unrelated to quality measures. And like I mentioned, that some of the products that are used to evaluate clinical quality measures seem to have been built with payers in mind and not necessarily providers. And that makes sense. Payers are the ones that are responsible at the end from a financial perspective for HEDIS, 5 stars, and other types of tools. But some of those tools do not work very well for provider organizations today. Okay, we'll move on to the next one. So here's one that my team has spent a lot of time with, and we're going to have a few slides digging into. So imagine instead of pulling the entire patient record from the HR, if you could pull only the patient's resources and time periods, like only information that could be needed for clinical quality measures. And on the right-hand side, you can picture, let's imagine that this is each of those dots is a data point about the patient in the HR. You could use those G10 APIs and just reach in and grab the relevant information from Michael Westover that could theoretically close quality data. Now, the pros about this, and there are pros and cons, pulling the targeted resources puts much less stress on the EHR and the systems. Some of those G10 APIs, like if you're going to pull all of the data for tens of thousands of lives, like 100,000 lives, like the query might just break, right? Or spin for a week and then just stop. If you're pulling targeted information, this can be effective. It also puts the provider in a situation to improve data quality because they're just pulling the relevant information and they can evaluate that information, put nice quality tools on top of it. And also this could be the provider's delegate, right? Like vendors that work with the pair. The G10 API data also might be more accurate than working with queries from reporting databases. We found that when we moved to the G10 APIs, the quality of our data and the amount of data that we were able to receive to close clinical quality measures jumped up a lot. And we'll talk about that. And that is meaningful, right? That matters for patient care, for having payers and providers thinking about it the same way. Like they both have the same picture of the patient's clinical quality profile. And patients are getting outreach to unnecessarily. Huge list of things that make you as a provider organization want to get as much data out of the HR and make it as accurate as possible. Now on the con side, it is more work to send targeted resources than to send the entire patient record because you need to know exactly what you need to reach in for, how you need to reach into the EHR and the G10 APIs. And you need to pull out just the information for just the time period, for just the right patients. Patient matching takes a lot of work to do well, and we do that outside of the EHR so we can get a higher percentage of patients that we can reach into and grab the information. So the truth is some providers do not have the resources or skills to take this approach, especially on their own. And that some of the G10 APIs offered by certified API offered by the HRs may not be responsive as you'd like. So because a lot of these tools are hooked into the production environment that the EHR runs, instead of being offloaded to a tool that's like really built to be like fast and to scale. Some of these tools can take a long time. Like for example, Providence, I think if we're pulling data for tens of thousands of lives, like that it can take a few days to get all the information that we need. And we would love for it to be instantaneous. Okay, so more about option 7. This is just a little bit more detail of how it works. So if you start at the upper left, we get attribution lists, which have these are the lists of all of our patients that we need to get quality data for. It could be all of the patients for a payer, or it could be a risk contract. It could be I don't know, chronic disease population, you can think. And we get this data in a FHIR format now from a few payers. And we're excited about that. The number of payers that are sending us ATR data is growing, and that is helping us be able to scale accuracy, huge benefits to getting that data in FHIR for any payers out there who are listening to us. And we also get flat files that are non-standard, like everybody has their own format. We get those too. We pull them into our data integration environment. Um, and then we use that information to reach out to, and we do some patient matching in our data integration environment. And then we reach out and we pull the relevant data out of the EHR. It mentions Epic on FHIR, the G10 APIs. And we have a chatty process to build all of the, like by patient, by resource, we'll pull all the information that we need to close clinical quality measures. We found that it would our EHR was actually more responsive when we pulled the data resource by resource and patient by patient than trying to pull the data using the bulk APIs. So the individual targeted queries seem to be more effective. So then we pulled just the relevant information. It's in FHIR, and it includes the relevant information, the admin data from the payer that we need. Then we put an API layer on top of it that scales really nicely. And then we have different payers that are connecting to that API layer. And it's really fast and easy for us to flip the switch and provide the data that is needed for those payer organizations. So the idea here is we want to do this at scale for our payer partners, where we can share all the clinical data necessary to close the quality measure gaps. And we have other APIs for other use cases too. But then we have payers that are not ready to accept, data and FHIR using modern APIs. And what we do with that is we take the FHIR data and we flatten it out. So it's in a flat file format with columns and rows, but it has all the benefits of the better data that we're getting out of the EHRs. And then we post that data on the SFTP servers for the payers. And then over time, more of our payers are moving over to that API, modern slick format. We're working with them on that. And so the idea is that flattened output is a bridge to the future of the APIs. I think you can envision some of the pros and cons of this method that we're doing. Getting in some of the details about pulling only the relevant resources. So we provide only the data needed for quality measures using FHIR CDEX. So CDEX is that national standard for exchanging clinical data. We're not exchanging all of CDEX, but just the relevant resources within CDEX that are needed for clinical quality measures. And we're also talking to payers about adding on a DEQM wrapper, which is another way that this data could theoretically be exchanged, when folks are ready for that. But currently we're exchanging that data via CDEX. And if we look at these are the measures right now on the right-hand side that we have in production that we're exchanging. We're looking at the heavy hitters, information that payers might not have access to, information that is a big part of our value-based care contracts, and information that is available to us. In yellow are some of the measures that we are in development. We also have a list of other measures that are on the docket that we're working with. And what we've learned in this journey is that some measures are easier than others to share. Some measures, the data is readily available. And others, you kind of have to work for it and go back and forth with your HR to tweak it and make sure that it can flow through appropriately. And then another important thing that I think we absolutely need to bring up is that there are measures related to sensitive data where it can be harder to exchange that data. So there are measures related to depression screening with follow-up, or measures related to substance abuse, where we need to have conversations internally about making sure that we're sharing that in a way that we're complying with state and national requirements. We need to be compliant, and we need to make sure that we're protecting the data, our patients' data. But also, we want to make sure that we're taking care of our patients' data and sharing the information that we need to. So there's some complexity here, but I feel like we've been able relatively rapidly to share a large number data for a large number of measures and close a lot of gaps for our quality measures in a way that our payer partners like going through these methods. Okay. Now, some of the impacts of these standards and modern APIs. So this is simplistic, and I hope in a future time we can get into a lot more detail about this. But we saw our performance on our value-based care contracts improve a lot as a part of sharing this data because clinical quality is such a big part of this. So for about 40 contracts where we're sending supplemental clinical data, we saw about a 40% increase in the usable clinical data for quality measures for the measures that we were sharing with our payers, like that was coming out of these G10 APIs. So this is a big deal for us. You could say part of that 40% is maybe your queries weren't strong enough. Part of that is, and we talked to our EHR vendor, they said they've been working really hard on their G10 API mappings to make sure that data is coming through cleanly. But through a combination of these reasons, we saw a big jump in the quality of the data using the FHIR-based data coming out of the EHR. And we had an external team look at it. I can't share the numbers with you, but I think this means providers are doing the same amount of work, meaning this is just doing better at getting that information to the payers more accurately, more complete. And this had a significant impact on our revenue, on patient care, on the wasted resources of calling patients to fill quality gaps that they really don't have because the data didn't flow, annoyance to patients, relationships with payers. I mean, there is a big list of why this matters. And then on the right-hand side, this is the courtesy of the multi-care folks who might be on the phone today. They also saw when the payer provides that ATR data in a FHIR format that they then use to bump up against the AHR to pull the clinical information, they saw a giant match in that patient matching, which means less individuals manually matching patients. You're not pulling the wrong data for a patient, which can have a negative impact on patient care, quality measures, negative impact on audits, the health information management teams that are managing all of this stuff. So getting clean data from the payer and ATR and being able to send clean data to the payer back for quality measures through CDEX or through DEQM can have such a big impact. Like this stuff matters. Okay. And now
this is awesome, Michael. We have two questions before you jump into learnings, if that's okay.
Please.
One is from Dan at HRBA. Did you say how often you integrate the data in the Cosmos DB to update patient profiles?
You're talking about how we update the data? Yeah. So the way we pull it now is we pull all of the relevant we're pulling a pretty narrow data set. And so for the narrow population that we're pulling data for, that we know we need to go after, we'll pull the entire relevant data set, like all the resources that we need for the entire time period that we're going to send. So we tend to we're not doing an incremental build, which is partial answer to your question.
Awesome. And the other question is from Chris from Blue Cross Blue Shield of Mass. What about option 8, integration between payer and providers, internal HIE like software, HealthShare, Orion, etc.?
Yes. I think at the beginning you saw my other options. Absolutely, there are other options and ways to do this. And we'd love to talk more. I'd love to brainstorm with other folks about this too. But through HIEs, and I know there are other fancy ways to exchange data where you're sharing access to the underlying data tables too, that I've seen that have promise. Yeah. I wish we had time to go through every option. Yes, that is an option. Okay. All right. So some quick learnings. Through our experience here, we have grown, at least I have grown to believe that round trip feedback loop is important, and those that learn how to do it will outperform others. And you can see it at the bottom here. EHR sends data to the health plan, or it could be through the provider, but to the health plan that then is managed and goes to NCQA, and then there's performance feedback and ongoing feedback with EHR adjustments. Those who can close that loop and iterate on it to make the data better and better and clean up all those local codes and externally validated, that's not flowing through, these are the groups that are going to win. Like at a certain point, it doesn't matter how well you are doing at the front line if the information is not getting to the payer organization. Like it hurts patients, it hurts providers, it hurts the payer, it helps NCQA, it helps not like we need to get this information through, and having this feedback loop is important. Um, the so and a couple other important learnings: the process to get standards-based EHR data from populations in bulk is often not working in real-world situations, and we need to continue to push on that. We need to be able to get data out of the EHRs so that we can do things like this at scale, like that, and that could be through various means, right? That we talked about today. Patient identity and matching are still challenging and still not perfect. I know there's some really interesting things talked about at the national level on this front that I think are really exciting. But you know, if you just think you're going to submit a limited amount of information and get all of the data for a Mike Westover and a Michael Westover, nailing patient matching and patient identity is kind of a core of where you're going to be successful in this work, or you're going to fail. When it came to us doing the national standard thing, it was the hardest thing for us. The EHR reporting databases are generally not designed with interoperability use cases in mind. They're built for, you know, reporting and analytics and that kind of thing. But, you know, the data that's coming in through those 18,000 tables that we have access to, those locations, like it is hard to write data and do interoperability at scale the way those are designed today. And I hope those evolve and they have, you know, they're more fire-friendly options and scalable, you know, national standards-based options. But that I think there's no, and there honestly there likely are there. I actually know there are some EHRs that have some reporting databases that do this really well. But I also think there are others that need to continue to evolve. And then I also want to say that a small dedicated team can make huge progress on interoperability. With just a few people, you can do a lot here on providing feedback, pulling the data, sharing it through through partnerships with vendors. You can do much here.
Michael, we've
so I don't
got
know.
2 minutes and a couple questions in chat, but why don't you continue on? And then I don't know if you have to jump or if you have a few minutes to run over.
No, this is my last slide, but
Okay.
just I think it's important to think about likelihood of success, scalability, work effort, and expense of each of these. This is my subjective, you know, review of each of these options, and I think you could come up with others too. And why don't we go through the questions, and I'll just leave my question or two
Your
if we can
word
get to.
cloud. I love it.
Yeah.
All right. This is great. Question from Dan regarding the third bullet point on the, so 2 slides ago, slide 15.
Yeah.
Could you say more about the approach you've currently implemented regarding patient matching? Might get back to
Sure.
AT.
Yeah, and I know Multicare has some interesting experience on this too. So what happens is we pull the information out of our EHR and we pull the information from our payers into into our environment, and then we do patient matching, and we can do a really effective job on it. You know, we have tools that do that really well, and then we can get the EHR identifier. And so when we reach in to grab information out of the EHR, we know exactly who we're getting information for. And if we just use like a $ match criteria, we wouldn't be getting back as information on as many patients as we do using that external process.
Love it. Next question is from Michael from Velox Metadata. There are some limits to query on the VSD. For example, if biometric readings are not in CPT2 codes, did you try using time parameters instead, such as HEDIS measurement year? If so, what was more performant?
Yeah, Michael, I know Michael's great. I don't actually have the answer to that one off the top of my head, but my team might for you. We can follow up with you, Michael. I know where to find you. Yeah.
All right, we are at time. That was amazingly done. I think I got all the questions in the chat, but if I missed something, please come off mute and ask it. And Michael, thank you so much. This was fantastic. I appreciate you sharing this insightful, beautifully summarized experience with others. I think this will be very informative as people put their plans together, both provider side and payers working with providers. So very well done. And thank you again for your time.
Thank you so
I
much.
hope you'll all join us in 2 weeks at the next Trebuchet call. So mark your calendars or reach out if you need help figuring out how to get to this call again. It'll be the same Zoom link. And we thank you all so much. Have a great rest of your day. Take care.